The idea of a retrievable stent that can give you the benefits of having a stent, including the longevity. This is something that we just simply do not have on the market at all.
This product has a temporary scaffold. It goes like whoop, and perforates the blood vessel, allowing the plaque to fragment and open. That scaffold stays open. You get to build like a stent.
Getting FDA approval is a really big deal. If you don't get FDA approved, you could be the most amazing thing in the world. It's worthless.
This is not a scoring balloon that's got no added value on CPT scoring. This is a temporary stent that you can bill as a stent, even though you're not leaving a stent behind.
It is very important to not just, for devices, this is the way. This is the algorithm that you should apply, because otherwise you will end up with wrong endpoints. No one will stop you. You lose a lot of money and your device will not actually get picked up.
Two vascular surgeons walk into a bar and come out with a podcast. We are talking everything vascular and not. Welcome to the Life of Flow podcast.
Hello, everyone. Welcome to another episode of the Life of Flow podcast. And this one was fire. We had the amazing and fiery Dr. Anahita Dua. You guys all know her. She's a repeat offender here at the Life of Flow podcast. This episode is graciously sponsored by Reflow and Spur. So we go into all things Reflow, but we also go into all things innovation and how we can be part of the driving force of vascular innovation and exciting technology. So hope you guys enjoy. Vamos. Anita, welcome back to the Life of Flow. I think you are one of our few repeat guests, so we'll call you like a repeat champ of the Life of Flow podcast.
I like it.
Thanks for being here.
My pleasure. I'm so thrilled to be here.
Awesome. And today, this episode is graciously sponsored by the great people at Reflow. So we're going to talk everything and anything Spur stent and how this like cool technology is something that we're going to be using and how we're going to introduce it into our lives and into our patients' lives. So first, tell us, our audience knows you. We had you at Hendelot, which was super cool last time. Well, what have you been up to?
So I am a vascular surgeon at the Mass General and associate professor of surgery at Harvard Medical School. So I'm up to lots and lots of operating. But I also, my God, I got distracted by the stud that just showed up on the screen.
I got my Bad Bunny glasses. My wife is hating on me right now, but I am here because it is Anahita Dua.
Oh my God, listen to this guy. But as I was saying, what am I doing right now? Basically, I am operating a lot. I run an NIH-funded lab that actually looks at personalizing blood thinners, which is kicking off really nicely. I run a political PAC called Healthcare for Action that focuses on getting healthcare workers elected to Congress.
Let me just do 2 seconds of this because Anahita has been working really, really well and getting a political torque. They've done so much. I've supported them in the past. I will support them in the future. And for anybody out there, if you're tickled, is there a webpage or something that they could look at and maybe potentially get on board and helping us push certain agendas, if you may, that are logical, sensical, and with the intention to make the world a better place?
Yes, absolutely. If they go to Healthcare for Action, all one word, healthcarefораction.com, you'll get to see everything on there. The candidates we're supporting, why we're supporting them, and the reasons that we got into this in the first place. There's a strong board. It's all doctors. Basically, it's doctors and nurses and other healthcare professionals who believe in the idea of getting involved politically to make sure that the world is indeed a better place. So please check it out. And you can email me anytime as well about that. And then the third thing I'm doing is I do run a company that is focused on making a endovascular stent that is for abdominal aortic aneurysms that comes from the axillary arteries. So it comes from the arm. It's an 11 French device. We're the co-founders, and we're off to the races with that as well. So that's what's going on.
When do you sleep? Do you sleep? Are you a vampire?
I drink a lot of Diet Coke. So between getting up to pee and being
no.
jazzed, I don't need to sleep.
Oh, no. Okay. Good. Bad example for our patients, but that's okay. All right. Well, actually, just to bring it back a little bit to the political action, we need to do... Anita, do you know Dutch Rojas?
Oh my God, yes. I was just on his podcast, actually, very recently.
Okay. Oh, cool. Well, we got to listen to that then. Cool. All right, Anita. So you're also involved in research around the Reflow stent. So how do you get involved in it? How are you incorporating into your practice? And yeah, let's just start a discussion with that.
Sure. So I think the first thing before we even talk about any device is we got to talk about the problem. Basically, if you go back, 30 years ago, 40 years ago, we had patients that, of course, in the vascular space had blockages from calcium all over the place. But those blockages tended to be more like popcorn lesions. You got one small area that you need to get through, maybe rotor through it, maybe throw a stent down, balloon it. And we were getting away with that because we had pretty decent inflow and outflow. So if you got through the issue, you were pretty cool for a little while. But that has really changed with patients. I kind of counterintuitively getting better and living longer. So, like living with diabetes for 50 years now, instead of living for just 30 years, we're starting to see this horrific multi level disease. And then, of course, as you know, with diabetes, high blood pressure, smoking, you've got the predilection for this calcium in the tibial vessels. And now the problem is that the only thing that we have in the United States to manage these tibial vessels is just straight up balloon angioplasty, which we know from a lot of literature, from our cardiology colleagues, from our own literature in the SFA, that balloon alone is just not good enough. We need something else. Drug, disruption of the plaque, something to allow for that patency. Because I think historically, we were saying, look, if I get that good angio at the end, high five, I'm done. We all know that that's not the metrics. That's not the metric for the patient. It's not the metric for the FDA even anymore. They want to know, is this person's leg attached to their body a year from now? And the only way you're going to get that to happen is if you're going to ensure that the blood flow is going to stay open. So Reflow and the Spur stent is kind of a new way of approaching the plaque that is below the knee. Basically, what we're doing is coming in with a stent that has little barbs on it, and you actually inflate it right in the location, or open it up, rather, I should say, right in the location where you have that plaque, and it physically disrupts the plaque and creates little cracks. And then the whole thing, inclusive of the stent, is removed. So there's nothing left in the patient. But now, because you have these little cracks in place, you can potentially come back in with drug, maybe a drug coated balloon at some point, and you can actually deposit that drug into this area, and that will allow for greater patency. So the idea behind the stent is that you're actually getting that luminal gain, you're disrupting the plaque, and you're reducing that recoil and leaving nothing behind.
We had a great conversation here on the pod when they got FDA approved a few months ago with essentially founder CEO. And it was a great story of innovation. And just to bring emphasis on the point you did, which is, man, oh man, we need something. I've been doing the same old plain balloon angioplasty for 20 years. And you see how there's been increasing technology in a lot of more vascular beds, but not here. And unfortunately, we've missed a lot of opportunities because I mean, I was there when there was an intention of being, sirolimus, paclitaxel based balloons for the below the knee vessels. They screwed that study out multiple times. And I think in a way, I want to say is people have learned from the losses in the past and understood that the research had to be much better. That when you're looking at chronic limb threatening ischemia, it's not, you can't use these coronary endpoints. Like it just seems like we've matured as a group to figure out how to get these things approved. And now here we are looking at bioabsorbable stents for below the knee usage, scaffolds and temporary scaffolds for below the knee usage. And I start getting hopeful that we're tickling on stuff that actually makes a difference. Now, as long as reimbursement is aligned, because you know that's a huge component of this, and I think that these guys in particular have done a great job at that, then you're going to get adoption because it's not only you don't only need a cool device that works, is it's got to get paid, and if it can't get paid, nobody's going to use it. Period. End the story. And so I feel I feel good. I feel good. And honestly, I applaud you, Anahita, for being me when I was in your position, I couldn't get it through. I don't know. I guess I wasn't knowledgeable enough. I wasn't FDA knowledgeable enough. And now here I am kind of seeing everything from the sideline. And what I can say is thank you to people like you that are really understanding how to get this through. So what's your involvement with this particular project? How back does it go? Or have you been a late adopter of this technology? Or what's been your experience hands-on with it?
Well, I've used it quite a bit because we were part of the original study to ensure that this was something that was safe and that it did what it said it was going to do, which is give you that luminal gain that actually lasts longer than this gold standard, unfortunately, like you mentioned, which is the POBA. And of course, I'm most likely going to be part of the study coming up, ultimately moving in the future where these spikes will at some point have sirolimus on them, have paclitaxel on them, and maybe be able to get even greater long-term longevity of these vessels. So I was not involved in the original development of it. I really came in kind of the trial testing period. What is interesting about what you said also about the reimbursement, you're 100% right. The cool thing about this is that it is in fact a stent. It is a Spur stent. And so it reimburses as a stent because ultimately what the reimbursement, what the CPT code is supposed to be is labor. You working. What does that translate to? And by going in with this device and actually expanding the stent and then taking it out, you are doing exactly what you would be doing if you were deploying a stent. So the beauty of it is that not only you get all the benefits, but you also get the gain in terms of the reimbursement. So I was involved with kind of discussing that with the company, discussing where we would like to see a difference. For example, this whole thing about putting drug on it is a conversation that happened with us a long time ago. And obviously that's where the company is moving. And then, of course, as I mentioned, actually looking at the data and presenting the data so that vascular surgeons can understand where this would fit into their repertoire. For example, one of the questions that could come up is, okay, that's great independently. Are you replacing shockwave? Are you replacing arthrectomy? What is this thing? And kind of explaining to the group, certainly in my practice, it has been an adjunct where if I get that horrible, like, for example, shockwave says flat out, eccentric plaque, we don't do that great. This is different. This is a barb that will jab into that and push it to the side and give you that extra luminal gain that you may not be able to get. Nothing wrong with then doing shockwave on top of that to get it to be a little bit more easy to push away.
I got a chance to use it and it worked really great. I think that this technology breaks from what I'm seeing is something that what I wonder is how it's going to play with atherectomy. Before we go into that, I think it's my perception, and you tell me if I'm wrong, that even though we know that POBA sucks, there are a lot of people that are complacent and are not really that hungry to look for different things. Am I wrong? And if I'm not wrong, how do we inspire some curiosity in people to start looking for more innovation and trying new things?
You're definitely not wrong, but I don't think it comes from a place of complacency. It comes from a place of accountability. And I'll explain this. I'm a vascular surgeon, as I mentioned, right? You guys are as well. You know that if you go into a abdominal aortic aneurysm case and you pick a stent that sucks and the patient has a terrible type 1A leak or they rupture or something bad happens, you're going to be held accountable for the decision that you made and the outcome on that patient. We don't have that level of accountability in PAD. If a patient comes in and needs care and I could do XYZ to get them better flow, but I don't and they get amputated, no one's coming for me because there's no national metrics that say this is what it should be. If you're 2 standard deviations out of this, you're not doing the right thing. And like Miguel just said too, reimbursement doesn't align and the incentives don't align with doctors taking that extra whatever, 15 minutes to pull the IVUS or, the extra half hour out of their day to learn about this new technology. And so they just keep doing what they're doing. Some of it is ignorance. Some of it, again, is they just don't have to because there's not that pressure. And it makes it sound bad. It makes it sound like we don't care. It's not that. It's just that, again, like if the society as a whole, this again, bringing back to politics, the government as a whole is not going to put these metrics down and demand that this is the level of excellence. And so if anything needs to be changed, it's not going and talking to the doctors. It's going and saying, this is the standard of care. If you are doing PAD, this is the level you need to be at. These are the tools you need to be adopting. This is the understanding you need to have. And if you don't have it, you shouldn't be doing this.
The data purists are very nearsighted. And when you compare atherectomy and drug-coated balloon angioplasty or temporary scaffolding and balloon angioplasty, what you're going to notice is that you're probably going to get the wound healed. You're probably going to save the leg on episode 1. Because if you look at the timeline for most of these studies, it's like 12 months, 15 months. Of course, when you're putting POBA, plain old balloon angioplasty, against anything a little bit fancier, in the short run, it's probably going to perform okay. So from a limb preservation standpoint, is okay. But what we're missing, I think, is that we're not looking at time in remission, because these patients, you will get them out with a POBA, but they will unequivocally restenose, unequivocally reocclude, and unequivocally end up on your table again within the next 5 years. And so I think that's where we've been super myopic, Lucas. Like, why are some of our, big PAD-SVS leaders not supportive of some of this stuff? A, because it just doesn't, you sound good. It's not a good political bite to favor technology for some odd ass reason. But B, because we're looking at very acute data. And so if we start looking at down the line, like I have coronary stents that everything else goes down, and the coronary drug-eluting stent is still open in the tibial, for example. That when you add technology in the right time in the right place, you're going to probably get very good results down the line. I'm not saying everything out there is good, but I think that's a huge part of why this hasn't become a little bit more standard of care, Lucas.
Well, I think what you're saying is going to my point, and which is a lack of curiosity within our field. And we have an amazing interventional cardiologist here, and I'll applaud the culture of interventional cardiology, interventional radiology, and I would say that they are, as a group, more open to innovation, likely because of their constraints. That we can rely on open surgery, and then I think that that makes us a little lazy as far as like trying new things, inventing new things. That's just my observation as for our particular field in vascular surgery, and which is something that I think we should change to lead innovation and lead for new changes.
It's interesting that you mentioned that. As the interventionalist getting to listen in on this conversation, I find it so fascinating that you struggle with some of the same things that we do. I mean, we really live or die by calcium modification. And we know if you don't do proper vessel preparation in the coronary space, your stents won't stay patent. You're going to have stent thrombosis. You're going to have restenosis. And yet we don't always use all the tools that we have. The utilization across the country for intravascular ultrasound or OCT imaging, for instance, incredibly low. Data is super strong. It supports all of the hard endpoints, and yet we're not using it as much as we should be. And same thing with calcium modification, vessel preparation. We have all these incredible tools, and people who use them tend to use them very well and have very good results. And I think some of it is this culture change of understanding, yes, just because I've been doing it a certain way, and everyone cites I have acceptable outcomes, but what is an acceptable outcome? Are you really comparing yourself against this emerging standard when we have all these new technologies and therapies available to us?
The acceptable outcome is a really low bar.
Yeah.
I'll say that across the country, very low.
The percentage of progressive thought leaders in interventional cardiology and radiology is far above vascular surgery, because I think vascular surgeons are afraid that somehow their art form is going to be dissuaded, diluted, threatened by endovascular therapy, which is the dumbest shit. If a vascular surgeon, which there are today, I know some of you, I don't believe in stents. Like, what is wrong with you when these patients need them? So that's the problem, Lucas. That's why we're not audacious. That's why we're not pushing the limits. But with people like Anahita, with people like Brian DeRupertis, with people like yourself, we are getting there. We are pushing the boundaries.
Yeah, but the thing is, like, again, it's like why isn't there innovation in open surgery? Why isn't there? There's an economic incentive, right? But there's absolutely no reason we should be doing bypasses the same way we've been doing it since fucking the Bakey. Absolutely no reason, right? There should be, like, the key is human innovation. The literal key is just human innovation, human imagination.
But the problem is the money, right? Like, as someone who's in the innovation space, right? As somebody who, like, again, like, I can switch hats now, talking about the company that we have. It's the world is driven fully, as we all know, by finances. And, you go on a VC pitch or, to have a conversation, and you're just not able to really get out there what needs to be said in order to have someone really invest in this. The SBIR grants, that were grants that the government used to give out, small little business grants, just got completely defunded. We hope that, it'll come back, but they're gone now. And that's what launched a lot of companies, because that's non-dilutive money. So the problem is that, it's very easy to look back. I mean, you mentioned DeBakey. DeBakey, you're pulling the shirt off his back, stitching it in his back, going and put it in the patient. I mean, those days are gone, gone, gone. And yeah, if you took away some of the red tape, the excessive bureaucracy, the 70% overhead that is taken right out the gate when someone gets a grant on something or gets money in to do research, if that was managed appropriately and the goal was aligned, that the person that's discovering something and the institution potentially both really want to do something for the patient, I think you would see a lot more innovation. The problem is in the rat race that doctors are currently in, where it's RVUs and it's, did you finish your notes? How are you now going to come home and think about the way in which you're going to design something? It's just not going to happen. And there are people. Again, I mean, I'm doing it myself, but like, yeah, you can't sleep. It's certainly not a part of your day to day, and that makes it very challenging for people, even with wonderful ideas, to take it to the next level. And so I think if we really wanted innovation in that space, we have to do what we always do if you want something, invest in it. And I don't think we do a good job of that right now. And then the people that are investing in it, like the companies that we're talking about, we kind of, come at with a lot of scrutiny and attack instead of maybe holding hands and saying, okay, how do we prove or disprove this? And that brings me to the next part of things, which is the research itself. If you're going to do a study to test if something works in the same way that you did a study 35 years ago to test if something works, you got a problem already. So in PAD, what is the metric of success? Is it a leg that's not amputated? Is it the wound healing? Is it TLR? What is it? And, that's why Saval failed. But Miguel was talking about that earlier with Boston Scientific study with drug-coated balloons. I mean, it's pretty unanimous amongst people who do this that the reason that study didn't come out is because they used kind of the same endpoints that they've been using for years for other studies, and it just didn't fly this time. And so we as a community, us who do this every day, have to sit down, be aggressively involved, work with the companies, and say, these are our pain points. This is what we actually want done. And this is how you should design the study so it's not stupid.
But just to give you the type of nonsense that we have to fix, it's a drug-coated balloon below the knee, randomized POBA to drug-coated balloon with sirolimus. And so I use intravascular ultrasound for my procedures. So I optimize it to intravascular ultrasound. Well, the patient randomized to sirolimus drug-coated balloon. I used it. Everything went great. We were all very happy. I pulled the IVUS to go back and check on my post-operative result. And the person from the study said, you can't use an IVUS post drug-coated balloon. And I looked at him in awe. I said, why? Because the IVUS is going to scratch the medication off the wall. And I said, I guess that's where the intelligent conversation in the room just died when you just said that. And I said, who wrote the fucking protocol? It has to be amended. But that's the kind of stuff that we need to be like in the weeds, right? We need to get involved. We need to help these people. That's the dumbest thing I've ever heard. But anyway, I don't want to digress, but that was just the kind of stuff that was like, it made me think when you said that, man, we still have to get very involved. Don't let industry drive it. We have to drive it. Don't let industry be the bad guy. Let's work with them, right? There's no reason why we shouldn't be part of evolution. We're actually the people in the driver's seat for evolution.
100%. So what are the targets? So what are the endpoints? I think, Miguel, you have a really amazing insight into PAD and tying PAD into clinical data and then communicating that. So, you know, I know you think deeply about this all the time. What are the endpoints that matter, and how should we be testing novel technology, things that are out of the box?
It's very nice of you, Lucas. I don't know that I think of anything deeply, but I will say, first off, is I think we have to do a better job at pressure testing things before we even go to a first in human. Show me undeniably that you're scratching plaque away to call this an atherectomy device, right? Like that's the first thing that I think we're jumping a little bit too fast over. And so I think that needs to be done. Then I think that first in human studies have to be done very well and very thoughtfully. And I think that we need to use imaging at all levels, pre-interventional imaging with intravascular ultrasound, OCT, to your point, post-interventional imaging, and then follow up with some advanced ultrasound surveillance techniques. The fact that Saval got thrown out of our tool bag because it was, You're either patent or non-patent. Well, what the fuck happens with restenosis? What if this balloon has 90% restenosis and the scaffold has 10% restenosis? We couldn't measure that. So we lost an endpoint. And then I truly believe that we're getting a little bit better at understanding hemodynamics of the foot in CLTI, accepting, learning, and utilizing pedal acceleration time is a massive win, I think, for a lot of these patients. And then we need to marry wound and wound related objectives, right? Time to contraction, 50% granulation, size contraction acceleration. Not only that, but time to remission, pain free days, capacity to walk independently. None of these things are seen. None of them, right? It's like amputation free survival. That's either you got a leg or you're dead. And it's missing the point and trying to find the fine message, because there's a lot of messages that are that are subtle, but they're there if you look at the right things. I don't know, Anahita, if there are other parameters that you think we should be trying to incorporate.
You're spot on, actually. And I think you can actually classify it into two separate categories because this is what I've learned, as the years have passed and I've done research. There really are two worlds in 2026 that you have to appease as a new company with new technology. World number one is the FDA and what is safe. And that is step one for all companies. Why? Because that is the point at which they can potentially get acquired. Getting FDA approval is a really big deal. If you don't get FDA approved, you could be the most amazing thing in the world. It's worthless. Why does that matter? It matters because the FDA's endpoints are not the endpoints that, and this is the second thing that 2026 needs, are the clinical endpoints. What I am looking for in my patient to say, yeah, this thing is cool, I'd use this, is not the same thing that the FDA guy is looking for. We're both right, we just have different goals. And so companies tend to do their initial studies to really lend themselves to the FDA. Miguel was just saying about the kind of the idea about doing something inside a cadaver leg or looking at the histology. Reflow, the company that we're talking about, the Spur stent, they did that, and they have beautiful histology that clearly shows disruption of the plaque, which is awesome. So that says, hey, the thing that we came to do, disrupt the plaque, do we do it? Yes, we do. Now the next question, which is the question Miguel and I and you care about clinically, is so what? You did it up front. Is it going to last me? What's the durability on this? What's the inpatient, the instant restenosis and the outcome? And that is not an FDA question. That is a clinical question. So the company now has to pivot after they've spent all this time thinking FDA, all their people are FDA, all their paperwork's FDA, and move clinical. And clinical is much dirtier because success is measured differently. And in order for the company to understand that, they have to get people like us on their boards, like us on their steering committees, so that before they get to the point where they've spent $30 million on a pivotal, they've actually designed the study in a way, again, I'll say, that's not stupid. So that when they finally have their drug or their device hit the market, everyone's clamoring to get it because we know that it works. Thought leaders have said, and when I say thought leaders, I don't mean the person who's been around, for 50 years. We all know who's actually operating. And so those guys have to be the ones on the podium saying, I used this in these many cases last week. These are my outcomes. And this is what I think is good. This is what I think is bad. And I think we actually do a pretty good job of that in this generation, as long as we get the opportunity to be on those stages. And so if the companies can adhere to this thinking where they keep the FDA in mind, but they also start from day one focusing on the clinical outcomes, which we would do to define for them, that's really the way to go. If you think of DVA that, Miguel and I were heavily involved in, deep venous arterialization is for no option patients that otherwise would be amputated. If you told me that DVA works 40% of the time, but otherwise 100% of the time the patient would get amputated, 40% is awesome. But for a different device, 40%, I may be like, I don't know if the cost is worth it. And then we would have a conversation. And so it is very important to not just, for PAD, for devices, this is the way, this is the algorithm that you should apply, because otherwise you will end up with wrong endpoints. No one will stop you. You lose a lot of money and your device will not actually get bought and picked up.
So let me just, for the audience, explain why there's financial viability to this particular product, just to like lay it very clearly foundationally there. This product has a temporary scaffold. All right. So it's a balloon. You put it in the tibial vessels and you inflate it. And then this matrix, this metal matrix, think of a metal porcupine, goes like whoop, and perforates multiple times the blood vessel in a very controlled way, allowing the plaque to fragment and open. Then you deflate the balloon, that scaffold stays open. So that scaffold is the reason why you, as an operator, for all of you listening as you're driving home or going into a case or what have not, is you get to build like a stent. You can say, well, Miguel, that sounds crazy. You don't put a stent. No, you don't actually leave a stent behind, but it is a stent like scaffold that's against the wall, and you leave it there for a certain amount of time. And you can all discuss this with your representatives. But all to say, that's where the edge is. So this is not a scoring balloon that's got no added value on CPT scoring. This is a temporary stent that you can bill as a stent, even though you're not leaving a stent behind. And you could say, well, that sounds kind of like crazy. But then if you think about it, we've got bioabsorbable stents. So then we put a stent, but it's not there 12 months later. So was that should you have not billed for a stent? You should, right? And so that's where they found this very interesting, I would say, middle ground that allows them that financial viability. What needs to happen now, I think, is they have to pair that up so that conceptual stent frame. Now you have to absolutely show me that there's a long-term advantage for adding the cost. Because otherwise, should I just use a scoring balloon or should I just use a plain old balloon angioplasty? And I know, Anahita, I had a chance to see your presentation at VEITH, and I think that's a great thing to maybe tie into this part. Whereas it seems like the company is not only looking at what that long term patency is, but then also how do you start weaving biological effects? Because now we have drug coated balloons, drug coated devices. Where is the company at? And maybe, for those that didn't have the opportunity of seeing you at VEITH, talk a little bit about what that presentation was all about.
Yeah, of course. No, my pleasure. So, right now, it's all about just kind of introducing the topic, right? Like introducing what is this thing? Because to your point right now, as you were describing it, this is something that we just simply do not have on the market at all. The idea of a retrievable stent that can give you the benefits of having a stent, including the longevity. I think that's the part that people get a little confused about. Like, I don't understand. I open it up, I put the spikes in there, then I take it out. How are we still not getting that recoil? And the reason is, of course, because you, again, disrupted that plaque in a very controlled fashion, created kind of these microchannels that allow you to then come back with a drug-coated balloon and actually get penetration of that medication, which ultimately can result in long-term durability, which we already know from multiple studies. So what the specific talk was at VEITH is kind of just introducing the topic and then introducing some of the data that's been out there. We started out, this is not going back years, with just a few patients for the first in human. And what was really happening is using the Spur stent and then using the Lutonix drug-coated balloon and then following up at a 1 month, 6 month, 12-month time period. We always followed up for about that time period, 1 month, 3 months, 6 months, 12 months. After that initial first in human study, we went over to Europe and did quite a large multi-center study that again showed Spur along with paclitaxel getting pretty good long-term durability. Again, when you're talking about endo, 1 year, 2 year durability is pretty good. And now the next step, after we've done a few studies, we've done other ones too. Deeper Reveal has come out now. Deeper Limus has come out, which is again across the world. The Deeper Reveal one, which was the one that was done in the United States, had 130 patients. And that was where Spur got its FDA clearance. So that's really important because at this point now, they're all clinically focused because now the FDA is out of here, as I was talking about earlier. So now they've talked to clinicians and said, okay, what do you want? And the obvious next step would be taking the Spur stent, and instead of doing Spur and DCB, you take the Spur stent and you just put the drug right on the little barbs. Why do two things? Saving time, of course, and ensuring that you get that real penetration. And so that's the next step in the process. I also did show a case at that time, just not to say, here's the durability. That's not the main thing, but just to show what can be done with the Spur stent. One of the things that hasn't been mentioned yet is, unlike an actual stent where once you deploy it, that's where it is, you can actually use the Spur stent 4 times inside a patient. So you can deploy it distally, then bring it up, do it again, bring it up, do it again. And essentially within 4, you'll be able to get the entirety of the tibial. So that way you don't have to open another device. So pretty cost effective, and certainly cost effective if you then end up with getting a situation where they don't need to come back for another intervention because they don't get that restenosis.
If you have a particular reason for treating the posterior tibial, then you treat the tibioperoneal trunk and then you treat the perineal. You're talking about 3 billable segments. And I don't want to digress from the science, but I think a lot of people that listen to us also care about how can I make this financially possible. And I'll tell you, in the OBL, if you plan a case very appropriately out and you know exactly where you're targeting and you have ultrasounds the quality of Jill Somerset, you can know that you're going to use that for maybe 2 or 3 segments and you can make it financially viable.
Yeah, just wondering, like, how do you implement this and how do you make this yours in your workflow? We all do things a little differently. I immediately start thinking of how to incorporate it with debulking, if it needs debulking at all. When does it need debulking? Um, then you start thinking about angiolithotripsy. Is there any sense in using it in angiolithotripsy at all? In my mind, it doesn't really compute that, why you would need both, but debulking does kind of make sense, and I can put it together in my brain. So how are you looking at this?
So it's interesting. I do see some synergy between doing lithotripsy and this, and the reason is because with lithotripsy, you're basically creating those cracks, right, in the plaque. And the ultimate goal of anything we do is to get this plaque to shatter and go away, right? Not go away, embolize, but move out of the way. And so that is obviously tied directly with luminal gain. And the more that you have shattered these sheets of plaque, the less likely the whole thing is going to be able to recoil. Even if a couple of pieces here and there start to do something, you're not going to get these sheets coming back in and us losing that luminal gain and ultimately resulting in, low flow state and then thrombosis. So in my mind, the way I've been doing it is I'd shockwave and get cracking first of the plaque that is there, and then the Spur stent to really get that gain and make sure that that gain is appropriately concentric. So the diameter is the same in all directions, right? Because if you use a balloon, a shockwave balloon, and let's say there's a piece of eccentric plaque that's pushing in, your balloon is going to take that weird shape, right? Where the eccentric plaque is pushing in. But with the Spur, you're going to get the same luminal gain, whatever size you use, of that particular stent. So now that's going to lend itself to laminar flow. And the hemodynamics are going to lend themselves then to not thrombosing, which is your ultimate goal. So that's how I see that synergistically. But you make the excellent point. Debulking, of course, again, same concept for that luminal gain. And, Trisha Roy, good friend of mine as well, and a perfect person to be talking about here. Dr. Roy is, I think, the highest funded vascular surgeon in the country currently, and it does a lot of work on a plaque morphology. And in conversations with her, she's told me that she's been able to identify 10 different types of plaque. Here we are talking about plaque, like it's all the same thing, like, all cancers are cancer. When, there's speckled plaque, there's Tootsie Roll plaque, where like the soft parts in the middle and the hard parts on the outside. There's calcific plaque, there's soft plaque that, in younger people from the lipoprotein A high numbers, and all of these react differently. And so I think what Miguel said about us now taking the charge, using imaging, starting to decipher the different types of plaque, and then saying, hey, Spur stent is awesome for this situation in conjunction with shockwave, but maybe just POBA is amazing for this situation. But we're nowhere near that yet, and we won't be able to do that until all of these devices are at least FDA approved and then in our hands so that we can start playing around with them.
The beauty about having OBL is no red tape. I bring a device tomorrow and test it in your lab. I'm like, is it FDA approved? Yes, done. New IVUS, the megahertz clarity. It's crazy what you can see with it. So I think this first gen, what a Boston Scientific has one, Philips has one. They suck. It's like looking in the middle of a winter blizzard. You can't tell shit, right? I mean, maybe you can make the rim and maybe, say, hey, it's a 3mm bristle, but that's it. You're not seeing anything. The new devices coming out are going to be amazing. And I think they're going to be game changers. And here's one fear I have, is along the lines of what you just said, Anahita, is I think tibial vessels as opposed to coronary arteries that are 6 centimeters long from, A to Z, they're 40 centimeters. And I think the plaque that we're going to analyze, and we know this from Ferraresi's histologies, Trisha Roy's MRI studies, every segment of that artery is effing different. What I fear is that you're like, oh, I'm going to have to shockwave the third. I'm going to have to DCB the middle, and then I'm going to have to atherectomize the proximal third and put a tack. Maybe, like, I know it sounds crazy, but maybe that level of detail is what we're going to get to be able to get good results. And then the cost of the devices just need to simmer down for that to be viable in the American healthcare system, which has already gone to shit. But that's my biggest fear, is that I think that we're just overly simplifying an incredibly complex problem.
Yeah.
I'm curious, how comfortable are vascular surgeons interpreting intravascular imaging results? Because that's been one of the really big barriers in the coronary space, where we don't have a lot of comfort in terms of what we're actually looking at if you haven't studied the intravascular imaging tech in more detail.
I would say that we're all guessing. We're all guessing and we're all giving things our own interpretation, and there's no cohesiveness. That is probably my guess.
That's
Right.
true. And there's some that are excellent. I mean, almost seeing things that aren't there. And most of us are living in the dabbler world. Anybody who's trained really in the last, decade, 15 years have used IVUS for TVAR, sometimes EVAR, any venous work, when we're doing like Natherners, things like that. I mean, it is always appropriate to use IVUS so that you can size your stents appropriately. So being able to generically just say, okay, I can measure, which is what IVUS was originally, brought into the field for. Then it started to get into this like now plaque morphology, and there's a lot of controversy also about like, is it outer to outer, inner to inner? Like how do you size this appropriately? And so there is a little bit of learning in that space, and certainly, I mean, to answer your question, not everyone is at the same level, and it goes right back to what I was saying earlier about having standards. We have to, as a community, say that right now, you're a structural cardiologist. If there must be standards in your field that say, like, these are the things that you need to be achieving, and these are the outcomes that you need to have in order for you to be considered a structural cardiologist and keep your privileges. We do not have that for PAD because it's just like anyone can kind of do anything. And not that people are doing things that are untowards, but like, we can't claim ignorance anymore when people's legs are getting chopped off. And there's a sweet spot. I mean, some people need open, some people need endo, some people need a combination. Some people get, nowadays, as Miguel pointed out, we're not seeing a one and done. I see a guy at 65 and I do a little SFA thing on him. And by the time he's 80, I'm doing his bypass.
So you think about like a staged approach, which is super, super important. It's analogous to what we do in structural intervention. You're not thinking about today, you're thinking about 20 years down the line. What is the life expectancy of this person? And I think that's where the multidisciplinary part, especially from a cardiology standpoint, if we as interventionalists are participating in that space, we have to be able to have conversations with people like you if we are the ones doing any kind of endovascular intervention. Because it's not just about today as the time point, it's about the future as well. And we don't have the surgical option skills that you guys have, and we don't know your data to that same degree. So I think it's super important to have that multidisciplinary approach.
Is there anyone that is the IVUS, girl or guy out there that's the geek that's like, taking it?
Eric Stemsky.
Okay. Why hasn't he been on the podcast, Miguel?
Eric is your guy. Sweetheart, nice guy, very smart, and knows a lot about this. And actually is the one who probably could say how it could be integrated in. But one of the things that we do when we talk about these things is we silo it. Like, we're talking about the patient outcomes. We're talking about how the doctors learn. One of the giants that push whether or not we do something or learn something is the logistics. In fact, I would argue that as an attending, that is 50% to 60% of my decision making. If I'm sitting in where I am, all angio procedures are done in the operating room, full anesthesia team, the whole deal. Okay. So that means that I don't have the luxury of 6 hours of time to be able to do these, because there'll be complaints and like, why are you using the space for this thing? Our cath lab doesn't, they also do PAD, but it's separate. It's done by our cardiologist. We don't go there. And so, if I'm now pulling the IVUS and it's like that movie 50 First Dates, every time's the first time. There's no protocol or there's no like definitive, like, this is really going to make a difference.
When are you opening the Anahita Dua Center for PhD Excellence on your own? How long do you think it'll take, Miguel? Give it over under.
The day that site neutral payments become a thing,
Yeah.
they're going to be incredibly supportive for her outpatient practice to start. The fact that minimally invasive care nowadays takes care of maybe half, if not even a little bit more, of these patients, but they're still being done, as you said, under general anesthesia.
We don't do it under general. It's just that the anesthesiologist has to be there. So it's worse actually. So they're getting sedated, but the anesthesia team. Yeah, I mean, I could even make an argument if they were actually doing They're no. Like I said, so it's worse. And we're trying, but these logistical barriers are so extreme. If it's taking longer to get in the room and do the anesthetic, sedation setup than it is to do the procedure, I'm not gonna IVUS and this, that's not gonna happen. Then you're talking about, okay, this is all the operating room and the shelf space has operative stuff on it. Now you want to put the Spur stent and the shockwave and who's gonna do so that's where we get into issues. And so again, I think we've gotten and there are enough patients, it's enough of a chronic health issue. It's enough of a burden on the Medicare world that we need to really say what centers of excellence are the way to go. How do we get everyone to one standard? And what needs to be in a cath lab or an OR or whatever as the bare minimum to be able to say it's a PAD space.
The fact that these hospital administrations, as you know, I'm very, anti-hospital, they make us the responsible party to bring technology in, and then they vet the crap out of it financially, but they make us be like the responsibles. So it's like, listen, I'm not going to get that product through the door unless Dr. Anahita Dua starts a process of administrative reconciliation for that particular Spur stent. Why is that? Like, why do we have to be the ones that carry the burden of having to decide what sort of process these hospitals need? If you have an FDA approved device that has shown clinical data, it's your damn job to get it through the door, not mine. And I should not feel accountable. Like physicians should not be held accountable to wanting a device that costs $1,000 more, $1,000 less. Like I'm going all the way out to the last mile. The last mile is if the FDA says yes and the data says yes and the CPT codes say yes, trust me, you still have a huge mountain to cross, which is get through the evaluation committees. And you have to find physician champions. Why?
Right.
Why is it that you need a physician champion to get a product that clearly has demonstrated data-driven good outcomes? You, as an administrator, should get the hell, out of the way and get this product into my practice. But it's almost like they've created this environment where we're always the ones at fault. So if that product for some reason goes to shit, or something comes out and they're like, oh, this graft doesn't work, it's super porous, they're going to go back to Lucas Ferrer and say like, hey, you're the one that signed that thing to get it into the hospital, bro. It's your fault for getting it in. It's just the whole thing is upside down. But I do believe that innovation and data are coming together. I do believe that we have the right wins, Lucas. I do believe that we have people like Anahita that we all look up to guide us through these murky times.
I will say, Miguel, to that point, I know I can tell you the answer why. Why? Because the incentives are not aligned. We want to do something that, even as selfishly as doctors, I am going to spend, 40 years of my life doing this. I want to use new technology. I want to learn new stuff. I want to advance the field. Simultaneously, it happens to align with the benefits to my patients, which is that I'm using new technology and better things. They get better outcomes. Awesome. What is the hospital trying to do? Save money. That's what they're trying to do. And if the government, and again, I come back to the government, if the government doesn't incentivize outcome, I'll tell you this, if tomorrow the government had a committee that came out and said, listen, we are not reimbursing for any procedure where the patient's leg does not stay attached to the body for greater than 6 months, the entire system at the VAC committee would change because now suddenly they're going to lose money by not bringing in the fancy equipment. It probably costs more money to have an anesthesiologist give general anesthetic than to just put some bourbon on a cloth and make somebody just hold still while you amp their leg. Why do we have anesthesia? Because those are the rules. And so the problem is the fighting is at the chicken level, you and me fighting against admin who are given different marching orders. And if we all took our orders from the top, which were let's just have the best outcomes for the patients. And this is how we optimally pay for it, which, by the way, can be done. Then we will have a different type of society. But that's fundamentally what the problem is. You're at odds with the very people that are supposed to be helping you get the best patient outcomes.
Yeah. So, I mean, the first thing we should do is no hospital should get paid for an amputation on a diabetic patients with all the comorbidities without diagnostic studies, and if those diagnostic studies are abnormal, an angiogram. If you do that, your hospital will not get paid. Immediately, you would see multiple fold improvements in outcomes.
That's what I'm saying. There has to be, but maybe we are the ones that have to. But I get the hospital's point as well. Like, these things come out. Everything has decent data, and we ourselves have not created the metric system. We're doing the glass and the Wi-Fi and the this and that, and we haven't really been like, here's where the clinical needle has moved. We've done the academics, we've done the publications, but we've not actually done that secondary part. And so because of that, they're like, okay, this is just another stent. Why would I do this? This is just another balloon. Why would I, and so we have to make that argument ourselves and be a bit more compelling. But I think it's going to start again with us from the bottom, building up and saying, these are the right patients that are getting this particular algorithm. And this is why they will have these good outcomes. And then the government incentivizing us to keep legs attached to bodies. And we'll have a beautiful golden system.
Tie that into the outcomes you've seen using Reflow.
In the time that I have used Reflow, I've actually seen wonderful outcomes. Specifically, again, my big fixation is this below the knee, right? Below the knee, because that's where I really have troubles. I have seen, I've done it myself where I've done POBA and then I've waited a few minutes and then shot an angiogram and see the recoil almost immediately. I do not see that using the stent, the Spur stent. Specifically now moving forward, what I've really seen, which has been incredible, is that patients are genuinely getting the outcome benefits that they claimed that they would get, namely that durability. I myself was skeptical. The idea of putting a stent in and then immediately taking it out, am I really going to get that benefit of actually having a stent placed? And I am. And when I think of stent benefit, I think of people going a year or longer, not needing a reintervention, not having changes in the duplex velocities, because that's how I follow these patients. I bring them back 3 months, 6 months, 1 year. They get duplex velocity checks of the entire area that I intervened upon and ABIs. That's what I do with toe pressures. And I can actually see objectively that using this first stent has resulted in having duplexes that have stayed the same without that in-stent stenosis, and as a result, wounds healing, which of course is the main name of the game here.
All right. And with that, we will wrap it up.
You are a rock star. We are huge fans here at the Life of Flow. We're following your career, a step at a time, and anything that you need from us in the future, may this be a great platform for you to bring your message of unity, of advancement, and of sanity. Thank you.
Thank you. Thank you so much for having me.
All right, guys. See you on the next one. Vamos.